Hi everybody, welcome to our Next Gen NCLEX-RN review session. In this episode, we'll work through real-life nursing scenarios on psychiatric crisis. So you practice how to prioritize care using the clinical judgment measurement model. Let's begin. Here's our first setting for the case scenario. It said, the patient encounter occurs in the emergency department of a tertiary care hospital following an acute psychiatric crisis. The patient's chief complaint included agitation, food refusal, hallucination, with a height of 5 feet, 11 inches, weight 67.1 kilograms, a BMI of 20.6 kilos, no allergies. He is non-adherent to risperidone, which was prescribed 8 months ago. And his past medical history included outpatient treatment for psychosis 8 months ago. Again, non-adherent to risperidone. He is unemployed, software engineer, lives with parents, no substance use, non-smoker. For a family history, his maternal aunt has bipolar disorder and his father has anxiety disorder. Here we have the present medical history stating a 32-year-old male with an 18-month history of social withdrawal and declining work performance leading to job loss 8 months ago. Moved to parents' home due to financial strain and paranoia about the apartment surveillance. Reports a 1-week history of poor hygiene, no bathing, and a 5-day history of food refusal, believing food is contaminated with tracking nanobots. Parents note increased agitation, disorganized speech, and bizarre behaviors like covering mirrors to block transmissions. Brought to the ED by police after attempting to disable a traffic camera, claiming it was stealing his thoughts. Currently hypervigilant, whispering responses with auditory hallucinations and visual hallucinations. Now let's get into the patient's mental status examination. And so it looks like the patient is disheveled, poor grooming, and shaven. His agitated, hypervigilant, scanning environment. His speech is rapid, whispered, tangential, and he is anxious, blunted, affect. His thought process sounded like he's got some persecutory delusions, loose associations, auditory and visual hallucinations. He's alert, oriented ×2, disoriented to time, poor insight. We have his vital signs: blood pressure of 140/88, heart rate 96, respiratory rate 20, temperature 98.6 degrees Fahrenheit, and oxygen saturation of 98% on room air. Now, let's look into the patient's chart for the healthcare provider orders. Medication orders included olanzapine 10 milligrams, IM stat, then 10 milligrams PO daily, lorazepam 2 milligrams IM PRN agitation. For labs, included complete blood count, comprehensive metabolic panel, TSH, urine drug screen, lipid panel, CT scan of the head. And for monitoring, it had 1-to-1 observation, monitor for extrapyramidal symptoms, vital signs every 4 hours, and for consultation included psychiatry for schizophrenia evaluation, and social work for family support. Now we have the following lab values. For hemoglobin, 13.9, fasting glucose on day 1 was 90 milligrams per deciliter, fasting glucose day 2, 128. TSH is 1.6 milliunits per liter. His lipid panel, which is all about total cholesterol, is 192 milligrams per deciliter. Negative for urine drug screen, and the CAT scan of the head showed no acute abnormalities. Now let's look into the patient's nurse's progress notes. On day 1 at 7:30 in the morning, patient brought by police after public disturbance, reports voices and robotic insects threatening him, refuses food, citing contamination, blood pressure 140/88, heart rate 96, placed in seclusion room with 1-on-1 observation. Psychiatrist ordered olanzapine 10 milligrams IV stat. At 9:30, post olanzapine, patient calmer but reports persistent hallucinations, sedation, and dry mouth noted, awaiting psychiatric consult. On day 2 at 8 in the morning, patient accepted olanzapine 10 milligrams, PO, reduced agitation, but delusions persist. Fasting glucose 128 milligrams per deciliter, weight 149 pounds, reinforced medication adherence. This is a Bowtie test type, and I want you to make sure that you are scanning all through the clinical data and make sure that all your answers are cohesive. Now, we have the options for the following. For the potential complication, we have akathisia, agranulocytosis, tardive dyskinesia, neuroleptic malignant syndrome, and metabolic syndrome. Now, before you start picking your answers, I want you to make sure that you are looking at the patient's lab results and the manifestations, especially those related to olanzapine, which is known to cause some serious side effects. After that, I want you to figure out which complication best fits the scenario. So don't just go with what looks familiar. You need to match the patient's actual data. Let's say an elevation of the blood sugar, or let's say weight gain, with what you know about the medication. After that, you got to choose the assessment findings that clearly point to that complication. So go with the ones that directly support your choice. Now it's time for you to think like a nurse. So you're going to have to generate that plan, and you have to pick those interventions that are within the RN scope of practice. Things like monitoring, patient education, or making referrals, not prescribing or changing medications. And finally, you need to double check that everything lines up with what's in the patient's chart and their medication list. So let's go ahead and fill out the boxes here. What do you think would be the best fit for the potential complication? The answer is metabolic syndrome, because the patient is showing signs of early metabolic changes, and olanzapine is known to cause this. And it's not just about weight gain. This medication can cause elevation of the blood sugar, can cause cholesterol changes, and resistance to insulin. Now, going back into the chart, the patient gained 1 kilogram, right? So that happened within 48 hours. This may not sound like a lot, but this is a clear sign that olanzapine is starting to affect the patient's metabolism, especially in combination with a blood sugar increase. Now, you go back into the lab values, the fasting glucose of 128 milligrams per deciliter is also a big one. So it went from 90 on day 1 to 128 on the second day. So that's officially in the pre-diabetes range. And for someone on olanzapine, that is a red flag for developing metabolic syndrome. So I want you to keep in mind all these changes when somebody starts taking olanzapine. Now, for the incorrect options, we have neuroleptic malignant syndrome. This is a very serious complication that you would expect to see fever. There's going to be muscle rigidity, unstable vital signs, but we are not seeing these in the case scenario. And the patient's temperature and the muscle tone are normal this time, so we are not worried about the NMS, or neuroleptic malignant syndrome. Now, tardive dyskinesia is also incorrect here, because this condition usually develops after someone's been on antipsychotics for a long time, not just for a couple of days. Plus, there are no abnormal facial movements reported here, so we're gonna not consider tardive dyskinesia. Another incorrect option, agranulocytosis, is pointing towards a low white blood cell count, like around 2,000 for the white blood cell count. But in this case, our patient's CBC is totally normal. Also, when you are considering agranulocytosis, this is more of a concern when somebody takes clozapine, not olanzapine. So keep that in mind. Another complication that is incorrect is akathisia. This is a feeling of internal restlessness wherein the patient just cannot sit still. They might be pacing or fidgeting, but here the patient is actually calmer, not restless. Let's move into the assessment findings. So I hope that you have picked your 2 correct answers. We have the options: restlessness and pacing, white blood cell count of 2,000 per cubic millimeter, fasting glucose 128 milligrams per deciliter, involuntary lip smacking, fever and muscle rigidity, weight gain of 1 kilogram in 48 hours. The 2 correct answers for the assessment findings are weight gain of 1 kilogram in 48 hours. Why do you think that this would be our answers? Remember about the metabolic changes that can happen in a patient taking olanzapine. That's already a considerable amount of weight gain for that just 2 days, right? And the other answer that you need to pick is fasting glucose of 128 milligrams per deciliter. This is significant. Again, the blood sugar went up from the 90s in the first day, and on the second day, it went up to 128. This is very significant. And if you are going to answer the muscle and fever, muscle rigidity and fever, these are pointed towards tardive dyskinesia. And for the white blood cell count 2000, that is more associated with a granulocytosis. Now, for the restlessness and pacing, this is more associated with the akathisia, remember? So take note about this is that feeling wherein the patient cannot sit still. They are actually fidgety, and they're also pacing at the moment. Now, let's get into the interventions this time. What do you think would be the 2 interventions? We have options: monitor fasting glucose and lipid panel, discontinue olanzapine and initiate dantrolene, add benztropine for EPS, obtain an order for weekly complete blood count, refer to nutritionist for dietary counseling, and adjust to lower olanzapine dose. What do you think? Now, here we have the 2 interventions: monitor fasting glucose and lipid panel, and the other one is refer to nutritionist for dietary counseling. Why monitor fasting glucose and lipid panel? Well, as we have seen already, that this changed the patient's blood sugar levels. So we need to make sure that we can catch early on the huge changes in the glucose and also their cholesterol level. And this is part of our responsibility as nurses. Now, referring to nutritionist for dietary counseling is also needed here because the patient is gaining weight and their glucose level is climbing up. So it makes sense to bring in a nutritionist to help modify their diet. And this helps slow down or even prevent progressive full-blown metabolic syndrome. Now, if you selected discontinue olanzapine and initiate dantrolene, well, this is something that would be applicable if the patient had neuroleptic malignant syndrome, which this patient doesn't have. Plus, discontinuing the medication and starting new ones is a provider's role, not an RN's. Now, if you selected add benztropine for EPS, well, this is a medication that is used to treat extrapyramidal symptoms like tremors or rigidity, but that's not what's going on in this patient. And adding this medication is also not within our scope of practice. If you selected obtain an order for weekly complete blood count, well, we know that CBC is helpful if you're watching for a granulocytosis, but that's not the issue with olanzapine. Also, RNs cannot independently order laboratory testing. And if you selected to adjust to lower olanzapine dose, again, dose adjustments must come from the prescriber or the healthcare provider. Nurses can recommend or report findings that support dose changes, but we cannot do this ourselves. Now, my tip for you in this test question, always tie your answer back to the specific medication or the actual symptoms or lab values and what is realistic for an RN to do. And if you are not sure still, then you got to ask if the symptom matched the known side effects of the medication, or if this is a red flag complication, or if this is something you can do independently as a nurse, or if that is something that will require a healthcare provider to order. All right, let's move on into our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
This is saying the patient encounter occurs in the emergency department of a tertiary care hospital following an acute psychiatric crisis. So we have the same information, basically, admission data, medical history. So feel free to scan these before proceeding to pick the answers. We also have the same mental assessment. Basically, this is the present medical history. So feel free to read that one more time before you pick the answers. And we have the mental examination, which includes the patient's appearance, the behavior, speech, mood, affect, thought process, perceptions, and cognition. We already scanned this before. And the patient's vital signs as well. And we have the healthcare provider orders. We have medication orders, diagnostic, monitoring, consultation orders, and the laboratory results. And finally, we have the nurse's progress notes. And there's no update here as well. Again, feel free to scan this before you finalize your answer in this test item. It says here, the nurse reviews the patient's symptoms to confirm the diagnosis. Drag from word choices to complete the sentence. The phrase says, the patient's blank is supported by blank and blank and blank. We have the following options here: schizoaffective disorder, paranoid schizophrenia, auditory hallucinations, persecutory delusions, social withdrawal for E, and then elevated mood. We have suicidal ideation and visual hallucination. So what do you think would be the answers, especially for the condition and the evidences for that condition? Alrighty, I hope that you have picked the answers. For this test item, the patient's blank, that's actually paranoid schizophrenia. This is the diagnosis that makes the most sense based on the patient's symptoms, because they've had a long-standing history over 18 months of hallucinations, delusions, and social withdrawal with behaviors like disorganized speech and paranoia. So that lines up perfectly with paranoid type of schizophrenia, which is known for its positive symptoms like hallucinations and delusions. Now, this is supported by auditory hallucinations, persecutory delusions, and visual hallucinations. So let's talk about the auditory hallucination. In this case, the patient hears voices warning them not to trust others. That's a classic symptom of schizophrenia, specifically a positive symptom. And it's one of the most common types of hallucinations in people with this diagnosis. Now, for the persecutory delusions, this is when someone believes they're being watched, they're targeted or harmed. And in this case, the patient thinks traffic cameras are stealing his thoughts and his food is being poisoned. So these are clear signs of paranoid thinking, which is another positive symptom that helps confirm the diagnosis. And lastly, visual hallucinations. Our patient is seeing things that are not there, like robotic insects spying on him, and which supports schizophrenia. And we know that visual hallucinations are less common than auditory ones, but they can still happen in severe cases of schizophrenia and can further strengthen the diagnosis. Now, the other options are incorrect. So if you selected schizoaffective disorder, this is a condition that involves both psychosis and mood symptoms like depression or mania. But here, there's no elevated or depressive mood reported, just a blunted affect and anxiety that rules this out. Now, if you selected social withdrawal, yes, the patient is isolating himself, but that is a negative symptom. And while it's part of the schizophrenia, it's not specific enough to confirm the paranoid subtype. And positive symptoms are more diagnostic in this case. If you selected elevated mood, this would suggest mania or bipolar features, but the patient is not happy or energized. Instead, he is anxious and flat, so this one doesn't apply either. And if you selected suicidal ideation, well, that's totally incorrect because there is no mention that the patient has suicidal thoughts, so this option is not relevant. So for this type of item, especially with this drag and drop diagnostic questions, always go for specific defining symptoms, especially positive symptoms like hallucinations and delusions when you're dealing with conditions like schizophrenia. And I want you to use the scenario details to rule out other similar conditions like mood disorders or schizoaffective disorders, and always double check that the symptom actually appears in the patient's medical record. So I want you to keep that in mind. Let's have our third item. And we have the same admission data, same information for the medical history, and the findings for the present medical history and the mental status examination. Here, the task is for you to choose the most likely options for the missing information by selecting from the list provided. So here, the nurse evaluates factors contributing to the patient's non-adherence to risperidone therapy. Again, you're going to choose the most likely options for the missing information by selecting from the list provided. So I really want you to go back into the progress notes to understand what is really going on with this patient, why he is non-compliant, and go back into the past medical history as well and the present medical history. So here is the phrase. It states the patient's non-adherence to risperidone is most likely due to blank because of blank, ruling out blank due to blank. Now, to answer this question, you're going to apply clinical judgment to figure out why the patient is not taking their drug, the medication. So better look into the EMR entries, such as the medical and social history, the mental status exam, the progress notes, and you have to pinpoint the main reason the patient is not following the risperidone prescription. After that, you have to back up your reasoning with specific evidence, something that directly connects to the behavior. Then eliminate another possible explanation by choosing something that clearly rules it out, like a missing symptom or irrelevant history. So be careful with that. Now, this method will help you match the correct reason with the most appropriate and well-supported evidence. So let's take a look into the options. For the reason options, we have lack of insight into illness, intolerable side effects, and financial barriers. What do you think about the reason option here? What's the correct answer? Well, the main reason was... Okay, before we're going to do that, let's review the different options. We have evidence options, which include poor insight noted on mental status exam, reports of sedation or extrapyramidal symptoms, inability to afford medication copays, and intolerable side effects, financial barriers, substance abuse for the alternative reason options. And lastly, options for exclusion. We have no reported medication side effects, living with parents, reducing financial strain, and negative urine drug screen. Now, going back into the phrase, what do you think would best fit here? Well, the reason is the lack of insight into the illness. All right? This is because they do not understand, or the patient did not understand or accept that they are ill. This is really common in schizophrenia, and many patients simply don't believe they need medication. And if you go back into the mental status exam table, it specifically said the patient has poor insight, which supports this perfectly. Now, moving on, we're going to have to look for the evidences here. Because of blank. So what do you think would be the answer here? The correct answer is poor insight noted on mental status exam. We're not guessing here. The chart literally says poor insight. That means the patient probably does not believe anything's wrong in himself or doesn't think he needs help. And this kind of thinking is a major reason why people with schizophrenia skip medications. Now let's look into the next blank. It said ruling out blank due to blank. So let's take care first about the third blank here. So this is all about alternative reason options. And the answer to this one is intolerable side effects. We know that side effects can make people stop medication, but there's no mention in the case that risperidone caused any problems. If there were side effects like sedation or stiffness or restlessness, it might be worth considering, but in this case, there's nothing like that noted anywhere. Again, the word or phrase that you should pay attention here is ruling out. Okay? Now let's move on to the last blank. It said due to blank. Again, the options are no reported medication side effects, living with parents, reducing financial strain, and negative urine tox screen or drug screen. So this is the exclusion option. All right, and the answer to that is no reported medication side effects. This is what helps us confidently rule out side effects. And after checking all the relevant documentations in the mental status exam or the nurse's practice notes, it's clear nothing was reported about the patients having negative effects from risperidone. Now, why do you think that the other options don't work, like reports of sedation or extrapyramidal symptoms? So I want you to pay attention into the second table, evidence options. It said in letter B, reports of sedation or extrapyramidal symptoms. Well, this might apply if the patient were on olanzapine, but they're not showing up with risperidone in this case. Now, if you selected inability to afford medication copays, again, it's mentioned the patient has financial challenges, but there is no direct evidence they could not afford or access the medication, and living with family likely would help him. And so pay attention to that. Now, for the alternative reason options, especially the option saying side effects, there is no medication or there's no documentation that risperidone caused any actually that's on the reason options here. There's no indication that the medication caused any EPS, no sedation, or any other common side effects. It's just not there, so we cannot use it. Now, for the financial barriers in the first table, that is also incorrect because the patient does not have, or he does have some financial stress, but he lives with his parents, which likely makes access to medications easier. So there's no clear link between money issues and not taking the medication. Now, if you selected substance use, well, the ones ruled out by a negative urine drug screen, so drugs aren't a factor here as well. Now, pay attention to the exclusion options on the fourth table. It said living with parents, reducing financial strain. So this one supports the idea that finances probably are not a big barrier, but it's not as directly connected to the medication use as the lack of side effect is. And on the same table, it said negative urine drug screen. This one rules out substance abuse, but again, it's not one of the more likely causes of non-adherence in this situation. So in this test item, when you're asked to find out why a psychiatric patient is non-adherent, do not just jump into assumptions like side effects or cost of the medication unless you have clear evidence in the chart. And take note that in schizophrenia, one of the most common and overlooked reasons for non-adherence is poor insight into their own illness, and the patient doesn't think anything is wrong with them. So always link your answers back to the specific and documented cues, and make sure that you choose the exclusion that clearly rules out a tempting but incorrect option. So I want you to reflect your answers in this test item before you go ahead to tackle the next.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
We have the fourth test item. It says here, the nurse reviews the progress notes from day 1 to 3. Let's take a look. On day 1 at 9:30 in the morning, it reads, post olanzapine, patient calmer but reports persistent hallucinations, sedation and dry mouth noted, awaiting psychiatric consult. Day 2 at 8 o'clock, patient accepted olanzapine 10 milligrams PO, reduced agitation but delusions persist. Fasting glucose 128 milligrams per deciliter, weight 149 pounds, reinforced medication adherence. On day 3 at 2 p.m., it said patient continues olanzapine 10 milligrams PO daily. Day 3 reports feeling sleepy, dry mouth, and new constipation. States, people are out to get me, but less convinced. Agreed to group therapy today. His baseline, he refused treatment due to strong delusions. Agitation is mild, cooperative, no restraints needed. Baseline severe, required restraints. Eye contact, intermittent, improved but inconsistent. Baseline is poor, hypervigilant. Now for the blood pressure, 122/78, heart rate of 76, respiration 16, temperature 98.6, weight 82 kilograms, fasting glucose 132 milligrams per deciliter. Patient has pre-diabetes and history of non-adherence to antipsychotics. Reports chest tightness this morning, denies chest pain, EKG pending, refuses breakfast, citing poisoned food, noted pacing and muttering about hospital spies, pushed a chair when asked to sit, encouraged fluids and prunes for constipation, offered lozenges for dry mouth, educated on glucose rise, patient hesitant about medication due to side effects and chest tightness, fall precautions in place, psychiatry to review tomorrow. Now here, on day 2, the nurse evaluates the patient's response to olanzapine. Your role or task is to click to indicate whether each finding suggests improvement, worsening, or no change in schizophrenia management. Each row must have only one response option selected. So what do you think would be the matrix? Here we go. We had got the following findings: agitation, mild, cooperative. So what do you think about this one? Is the first finding an improvement? Is it worsening or no relevant change? Well, before you're going to select your answers, I just want to emphasize here that when you are dealing with this patient, you have to, of course, use the clinical judgment measurement model here. You have to start by analyzing day 3 progress notes. You got to pay attention to the patient's response to the medication, his history of prediabetes, and his risk of not sticking to taking the medication. So here you need to ask yourself if the symptoms are improving, if there are any side effects that could affect the patient's safety or maybe their willingness to continue taking the drug. So here you have to categorize each piece of data into 3. So if it's all about therapeutic improvement, this is the time when you see meaningful symptom relief. There is positive engagement, maybe benefits clearly outweigh the risk. Now, if you categorize something as clinically significant worsening, it simply means that there is new or maybe worsening side effects or maybe symptoms that could jeopardize safety or the comfort or medication adherence of the patient. While if you select no clinically relevant change, well, of course, these include the changes that are minor, expected, or don't impact the care plan. And also remember how olanzapine works. It can reduce agitation quickly, but dilutions might take longer for it to improve. So I want you to use the time frame. And of course, we have like 72 hours in this case, and the drug's expected effects and the patient's personal risk factors to back up with your choices. So going back into the finding, agitation, mild, cooperative, this one reflects therapeutic improvement. Because when the patient started olanzapine, they were severely agitated, right? Before, right? They were so agitated, and that's very serious. Now, just 3 days in, they've gone from being aggressive to mildly agitated and cooperating with staff. That's a huge turnaround in a short time. So this is exactly what olanzapine is known for. It works quickly to calm the patient and it will reduce agitation. So this level of improvement tells us the medication is doing its job, and right now the benefit definitely outweighs any mild risk. Now let's look into persecutory delusions, less convincing, agreed to group therapy. This one also reflects therapeutic improvement. This one's quite subtle though, but it's actually a big deal because even though the patient has delusions, but they're not as convinced by them as before, and now he is engaging in group therapy, which he refused earlier. And that shows a big shift in their insight and trust, even if the delusions are not completely gone yet. And remember, delusions take longer to resolve than agitation. So this early change is a strong sign the medication is starting to work on a deeper level, and the patient is showing signs of reconnecting with reality and becoming more open to help, and that is some progress. Now let's take a look on reports feeling sleepy, dry mouth, and new constipation. Well, this one is obviously clinically significant worsening because we are now seeing a cluster of side effects, and while they may be seemingly just moderate, these matter especially in this patient because the patient has a history of stopping in taking the medication. So things like sedation, maybe dry mouth, and constipation, these are very common side effects of olanzapine, and this can actually be a big barrier for them to continue taking this drug. And if a patient feels sluggish or uncomfortable, they may stop taking their meds, especially if they don't fully believe they need them. And that makes this clinically significant issue. And as a nurse in this case, you'd want to intervene, offer symptom relief, reinforce adherence, maybe suggest a dose adjustment to the medical provider. Let's get into the next finding. Eye contact intermittent improved. This one shows therapeutic improvement. Even though this seemed like a small thing, but in mental health, subtle behavioral changes tell a big story. And at baseline, the patient had poor eye contact and was hypervigilant at first, constantly scanning the environment on edge. Now, the patient's eye contact is still a little off, but noticeably better. And this one suggests less paranoia and more engagement, even if it's early. So yes, it's a positive sign, and it's worth noting that this kind of improvement often precedes deeper therapeutic changes. Finally, we have fasting glucose, 132 milligrams per deciliter, weight 82 kilograms. The answer is obviously clinically significant worsening. These two are red flags, especially for this patient, because this patient already had pre-diabetes. Now, his blood sugar has jumped from 110 to 132 milligrams per deciliter in just 3 days. And he also gained 2 kilograms. That's 4.4 pounds. That's a clear sign of early metabolic side effects, which olanzapine is very notorious for. So this is not just about numbers, and you got to pay attention that metabolic changes increase the risk for diabetes and cardiovascular issues, and they can make patients feel bloated, make them feel very tired and discouraged. And on top of that, if the patient notices rapid weight gain, it could fuel non-adherence. And so yes, this change is clinically important, and it needs to be addressed through monitoring, education, and possibly adjusting the care plan. All right, I want you to reflect on your answers in this test item. And if you've done that, let's move on to test item number 5. It says here, the nurse reviews the progress notes from day 1 to 3. It said, on day 3 of 1400, patient continues olanzapine 10 milligrams PO daily. Day 3, reports feeling sleepy, dry mouth, and new constipation. States people are out to get me, but less convinced. Agreed to group therapy today. Agitation is mild, cooperative, no restraints needed. Eye contact intermittent, improved but inconsistent. Blood pressure is 122/78, heart rate 76, respiration 16, temperature 98.6, weight 82 kilos, fasting glucose 132. Patient has pre-diabetes and prediabetes and history of non-adherence to antipsychotics, reports chest tightness this morning, denies chest pain, EKG pending, refused breakfast citing poisoned food, noted pacing and muttering about hospital spies, pushed a chair when asked to sit, encouraged fluids and prunes for constipation, offered lozenges for dry mouth, educated on glucose rise, patient hesitant about medication due to side effects, stated, I might stop it. MD notified of lab side effects and chest tightness, fall precautions in place, psychiatry to review tomorrow. Now, your task in this test item, it said here, the nurse reviews day 3 progress notes and identifies multiple clinical concerns. Drag and drop 5 of the 8 listed interventions in order of priority, 1 being the highest, 5 the lowest, to address the patient's immediate needs, balancing safety, therapeutic goals, and long-term management in the context of schizophrenia care. So, again, we have a bank of interventions, but you're only going to rank 5 of them. Okay, so we have our options for the nursing interventions. One of those options is administer PRN lorazepam 1 milligram IM for escalating agitation and behavioral escalation. We have initiate Ducusate 100 milligrams PO daily and dietary fiber for constipation. Obtain stat EKG and consult cardiology for reported chest tightness. Discuss medication hesitancy with a patient one-on-one to promote adherence. Monitor fasting glucose and request a nutrition consult for prediabetes management. Schedule a family meeting to discuss discharge planning and home support. And administer olanzapine 10 milligrams IM stat to address food refusal and paranoia. Lastly, request a speech therapy consult to evaluate disorganized speech patterns. So, let's talk about how to work through this priority setting question. So, you're reviewing the progress notes on day 3 for this patient. So, this time, your job is to prioritize those interventions. So, any urgent safety issues like cardiac symptoms or escalating agitation are the priority, and the patient's therapeutic needs and those long-term issues like metabolic risk or constipation will probably be of a lower priority. And you also need to keep in mind that the timeline is only about 72 hours into the treatment, and you've got to consider how olanzapine typically works. It's fast, it's also calming the patient's agitation, but it's slower at clearing the patient's delusion. And at this patient's personal history, the prediabetes, and the known pattern of non-adherence to the medication, so don't just pick what sounds nice. You got to think about what could hurt the patient first and what must be handled right away versus what can wait a little bit. So the first priority that you should put in here is obtain stat EKG and consult cardiology for reported chest tightness. Why? Because of his chest tightness, he said that. And noting that the patient is taking olanzapine, this one carries some rare but very serious cardiac risk because this drug can cause QT prolongation. It can also cause myocarditis, even ischemia. And anytime a psychiatric patient reports chest symptoms, you don't assume it's just anxiety or paranoia. You need to treat it as a possible emergency. And the EKG hasn't been done yet, so this is a very time-sensitive, life-threatening concern that jumps to the top of your list. So do not let cardiac red flags wait. Again, that is our priority. Now, the second priority should be administer PRN lorazepam 1 milligram IM for escalating agitation and behavioral escalation because the patient is becoming more agitated. They're pacing, they're muttering about hospital spies, and even pushed a chair. So that kind of behavior can escalate very quickly, especially in someone with a history of needing restraints. And lorazepam is ordered as needed, and it can help calm down before they harm themselves or other people, or before staff needs to physically intervene. So this is a behavioral safety issue, which places it just behind the cardiac concern. Now, let's move into the third priority here. What do you think would best fit in this rank? That should be discuss medication hesitancy with the patient one-on-one to promote adherence. Because this patient has made a clear statement that he's thinking about stopping olanzapine. He said, I might stop if it keeps messing with my head. And remember about their history of not taking medications. This is a major red flag. And if you don't intervene in this one, there's a high chance that they're going to stop taking this medication, which could lead to relapse, can lead to rehospitalization, or even more safety risks. So this is not a time sensitive. This is not as time sensitive as the cardiac or, let's say, agitation issues, but this is still urgent and also could determine long-term outcomes. Now, moving into the fourth rank, what do you think would fit here? Well, this is going to be monitor fasting glucose and request a nutrition consult for pre-diabetes management. Now, let's talk about the metabolic risk. The patient's fasting glucose jumped from 110 to 132 in just a few days, and he gained 2 kilograms. That's a sign that olanzapine is already impacting their blood sugar and weight, of course, metabolism. This is not an emergency, but it is a significant concern that needs monitoring, and we need to support him with dietary modification before it gets worse. So you would not delay this far too long, but it's okay to handle it after you have addressed the safety and adherence. Now, let's look into the fifth spot here. What do you think would fit here? The answer is initiate Ducusate 100 milligrams PO daily and dietary fiber for constipation, because he reported that his constipation, and this is a very common side effect of olanzapine. Now, they've already been encouraged to drink fluids and eat prunes, but now you're adding Ducusate, which is a gentle stool softener. This is definitely important for comfort, but let's be honest, it's not as urgent as chest pain or, let's say, aggression or stopping medication. And that's why it's the lowest priority among the top 5. Now, moving into the other options, there are also distractors here that did not make the cut. So if you selected schedule a family meeting to discuss discharge planning and home support, this sounds kind of productive, but it's way too early. The patient is still paranoid, refusing food, showing signs of instability. So discharge planning at this point is premature and distracts from more pressing medical and psychiatric needs. Now, if you selected to administer olanzapine 10 milligrams IM stat, or give olanzapine, I think there's that there's that olanzapine IM for refusal on the food and paranoia. Okay, this one is not in our priority because this is such a bad move here. The patient is already taking olanzapine by mouth, and their food refusal is not due to medication non-compliance. It is because they think the food is poison. So if you're going to give more olanzapine, especially by IM, it doesn't treat that paranoia. It could just worsen the side effects like sedation or metabolic problems. Now, if you selected to order a speech therapy consult for disorganized speech, this is also incorrect because this one's a red herring. There's no mention of disorganized speech in the progress notes. And even if it was there, speech therapy doesn't treat communication problems caused by schizophrenia. No, they don't. So those are things that are managed psychiatrically, not through speech rehabilitation. Now, what's going to happen if we misprioritize here? Let's say you placed one of those distractors in the top 5 or pushed down a critical one like the EKG or lorazepam. That's a problem, because if you're missing the cardiac red flag, such as placing EKG or cardiology lower than 1, you could actually miss a very life-threatening event, right? And if you delay lorazepam, patient or staff could be harmed due to agitation, or if you're ignoring medication hesitancy too long, the treatment failure risk will also skyrocket here. And if you're going to put glucose checks before cardiac issue or agitation, then you're focusing on long-term risk over immediate threats, which is not going to help this patient. And if you're ranking constipation higher than cardiac or adherence issues, then you are prioritizing comfort before survival, which is never the right call. So when you are prioritizing care, you definitely start with safety, such as cardiac symptoms and behavioral escalation. Those should go first. Then you need to manage adherence risk, especially in patients with psychosis and a history of skipping medication. And after that, you tackle metabolic concerns and other side effects. And make sure that you avoid premature or irrelevant interventions, because they can distract you from what matters most. So this is what real clinical judgment looks like. So you need to balance what's urgent, what's treatable, and what keeps the patient safe today and stable tomorrow. Let's move along on our last test item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Here's an update regarding the nurse's practice notes. It says, on day 3, 1800 hours, the patient remains on olanzapine 10 milligrams PO daily. EKG results are normal, ruling out cardiac issues for chest tightness. He reports worsening sedation. I can't stay awake and constipation. Delusions persist but are less intense. He states, the food might not be poison, but I'm still not sure, and accepts a sip of water but refuses meals. Agitation escalates slightly. He paces rapidly, clenches fists, and shouts, the nurses are watching me, when approached. Blood pressure is 135/85, heart rate of 88, respirations 18, temperature 98.7, fasting glucose drawn at 1600 is 138 milligrams per deciliter, weight 150.5 pounds. He expresses frustration with side effects, stating, these pills are making me worse. I won't take them tomorrow. A staff member left a stethoscope on a chair in the room. The patient picks it up, wraps the tubing around his hand, and mutters, this could stop them. One-on-one observation continues and fall precautions remain. Psychiatry review is scheduled for day 4. Now, in this scenario, based on the updated progress notes and prior context, select the 3 most critical interventions to prioritize for the patient's immediate safety, stabilization, and therapeutic progress within the next 24 hours. So we have the nursing intervention options. We have notify the provider of elevated glucose and request a diabetes consult. Is it apply soft restraints to prevent potential self-harm with the stethoscope? Or is it encourage the patient to attend a second group therapy session to build rapport? Or administer lorazepam 2 milligrams IM stat for escalating agitation? Or remove the stethoscope and other potentially harmful objects from the room? Or re-educate the patient on olanzapine benefits to address non-adherence concerns? And lastly, request a stat order for a laxative for unresolved constipation. So in this case, using the clinical judgment measurement model, you need to decide what actions the nurse should take in the next 4 hours because the patient is showing some clear signs of worsening behavior. So this is all about spotting immediate risks like agitation or possible self-harm and refusal to take medication. So you're asked to choose 3 priority interventions. So how are you going to decide here? So first thing you need to do is you need to think like a nurse at the bedside. What is going on right now? And look at day 3, especially 6 p.m. note. Consider what has changed. So you got to focus on what you can do within your scope of practice, right? No ordering medications or adjusting diagnosis. So think about the CJMM steps. You need to analyze the cues. So what are the red flags? You need to prioritize the hypothesis, what's most dangerous, and take action. What can you do to stop this from getting worse? So those interventions should include administer lorazepam 2 milligrams IM stat for escalating agitation because our patient is pacing really fast, clenching his fist and shouting, which are all big signs of agitation. This could really spiral into aggression. And the vitals even back this. The blood pressure is elevated, the heart rate, which is often accompany the agitation, and thankfully you've got the PRN order, the lorazepam, which is really going to help this patient. So the lorazepam is used to calm the patient very quickly, so to prevent from harming themselves or even the staff or others in the unit. So this is absolutely within your nursing scope and a critical first line intervention in the next few hours. Now, another intervention that you should select is remove the stethoscope and other potentially harmful objects from the room because the patient is wrapping the stethoscope tubing around their hand and saying things like, "This could stop them." So this is very concerning for self-harm or violence tied to their paranoid delusions. So this is not the time to wait or second guess. You take action right now. And as the nurse in this case scenario, it's 100% your responsibility to remove potentially dangerous objects right away, whether it's medical equipment, maybe sharp items, or anything they could weaponize. So this is a very simple but powerful safety intervention, and it must happen immediately. The other intervention that you should implement would be to re-educate the patient on olanzapine benefits to address non-adherence concern. So here's the subtle but very serious risk. The patient just said, "I'm not taking them tomorrow." And that might sound casual, but in someone with a known history of medication non-adherence, that's a warning, especially since this patient previously stopped taking risperidone, and this is a pattern. So this is the moment for therapeutic communication. So you got to sit with them one-on-one and remind them of how the medication has helped them calm down, feel safer, and to reduce their paranoia. So this won't solve everything instantly, but it's one of the most important things you can do in your shift to keep their recovery on track and prevent relapse. Now, what's not to do right now? Well, one of those is to ask for a laxative order. It said, request a stat order for laxative. Yes, the constipation is uncomfortable and olanzapine can cause it, but this patient just started taking prunes earlier today and there's no sign of a serious gastrointestinal issue. So there's no obstruction. And this is not something that has to be dealt with in the next few hours. Now, if you selected, request, what do you call this? A consultation or something like that, because of the blood sugar level climbing to 138 milligrams per deciliter. All right, sure, the patient has prediabetes, and this is a huge change. But there's the thing. The provider was already notified. There's no sign of diabetic emergency, like ketoacidosis or the hyperglycemic hyperosmolar non-ketotic syndrome. So this is something that can wait until the more urgent issues are addressed. So do not pick this one. Now, if you selected apply soft restraints to prevent self-harm, to prevent potential self-harm, this is a big one. Restraints might be tempting when someone is escalating, but remember, they are a last resort. And in this case, the patient hasn't been violent or attempted harm. They're agitated, but manageable with other measures. So you already have PRN lorazepam. You have removed the potential object, which is the stethoscope, and you also have the one-on-one supervision. So using restraints in this case is a bit early, and this can actually escalate the situation and violate the best practice in this case. And if you selected encourage the patient to attend a second group therapy session to build rapport, well, this might seem like well-intentioned, but the timing is totally off. The patient went to group therapy earlier today, which is great, but now it's 6 p.m. and they're very agitated. He's paranoid to benefit from a group setting. And if you're going to push this patient into a group therapy right now, this could actually increase their distress or even cause them to act out. So this is not the right moment for social interventions. So the main key takeaway for this scenario, especially when you're making decisions about what to do in the psychiatric setting, you got to start with safety first. Ask yourself, is the patient at risk of hurting themselves or others? Or are they showing signs of medication refusal or non-adherence? Or are there red flags like objects that they could use to harm themselves or others that need to be dealt with right now? And once you have tackled those, then you can think about comfort issues or maybe long-term metabolic management or discharge planning. But when someone is pacing or let's say paranoid, and if they're threatening harm, you don't focus on constipation or glucose levels. You need to act fast to keep everyone safe and make sure you have to prevent a setback in their treatment. And so if you find this session very helpful, don't forget to subscribe to the YouTube channel for more NCLEX Prep content, and give this video a thumbs up and share it with your study buddies. Thank you for watching. I will see you again in the next session.